Anterior cruciate ligament tears are among the most common injuries we see here at the Steamboat Orthopaedic and Spine Institute, and it's one of my clinical passions. ACL surgery is also one of the most rewarding operations for us to perform, as it allows patients to get back to the activities they love and the lifestyle that they desire. For those patients that would like to avoid ACL surgery, often activities have to be sacrificed. The ACL is instrumental in supporting the knee, allowing you to pivot, twist, and turn. With a torn or absent ACL, those activities are no longer possible, or the knee may give out, give way, or buckle. When do patients need ACL reconstructive surgery? We like to assess the whole patient, both their symptoms, their physical exam, and what they're suffering in terms of how the knee feels. That's corroborated by imaging, x-rays, MRI, and of course our physical exam in the office. We look for things like swelling or instability, that apprehension or sensation the knee is going to give way, as well as additional injuries like meniscus tears that can commonly occur. ACL reconstructive surgery seeks to solve that. It restores stability to the knee, provides a stable base of support, and gives patients the limb that allow them back to the activities they wish. Well, reconstruction is the term for replacing tissue with a graft, and a graft is a piece of tissue taken from elsewhere. Those sources could include your own body, like an autograft, taking tissue from elsewhere or an unaffected region of your limb to restore the torn ligament. The gold standard, or most common, has perhaps been the patellar tendon, or the BTB graft. That involves taking a segment of bone from both the tibia and the kneecap, or the patella, and bridging the ACL with this new piece of graft tissue. Long-term studies have shown the patellar tendon graft is very strong and stable and allows for reliable return to activity. Disadvantages, however, include that it may contribute to knee pain. Patients with BTB graft harvest may suffer pain in the front of their knee, may struggle with kneeling, or may develop tendinitis around the patellar tendon in the long term. I found that some of my female patients tend not to do as well with the patellar tendon than those competitive male athletes, and that might be due to the kneecap being more prone in the female athlete to begin with. The hamstring tendon was my preferred technique for over 5 years. During that time, I surveyed my clinical results and found that the average tendon diameter was only 8 millimeters. The stability or strength of the graft depends on how robust and how large it is, and while 8 millimeters is acceptable, I found better results with quadriceps tendon. The quadriceps is the muscle on the top of our thigh. The 4 muscles are defined as the quadriceps, and they attach to the top of the kneecap. The quadriceps combine to form a broad tendon, and they measure 3 or 4 centimeters across. If we sacrifice or harvest the central 1 centimeter, leaving 75 or even 80% of the tendon intact, patients have little after effect or residual symptoms. Furthermore, the quadriceps tendon is soft tissue based. No bone is required or cutting of the bone to take the graft. I found that my patients have quadriceps graft surgery, have intact straight leg raise, strength of the quad even as soon as our first visit. That leads to be a minimally invasive, low impact and low morbidity graft site to take from, and it's become my chosen graft source.